Urinary incontinence. It's a huge topic, right? And it can feel super complicated if you don't have a solid framework to approach it. Well, that's exactly what we're going to build today. A step-by-step guide that turns that confusion into confidence. Let's dive in.
To really get this, let's start with a few classic patient stories. First, imagine a patient comes in and tells you they leak just a little bit of urine every single time they cough, or laugh, or even just pick up their groceries.
Okay, now picture a different person. They're totally fine most of the day, but then, bam, the urge to urinate hits them so suddenly and so intensely that they just can't make it to the bathroom in time. And for our third case, think about this, a patient who doesn't report any of those big leaks. Instead, they just have this constant slow dribble of urine all day long, and they always feel like their bladder isn't quite empty.
So, 3 totally different experiences, but they all fall under this one big umbrella of incontinence. And this brings us to the single most important idea we're going to talk about today. If you can nail down the type of incontinence, the right treatment plan just clicks into place. So, here's our game plan. We'll start with how the bladder is supposed to work. Then we'll get into what happens when that control is lost and break down the different types. After that, we'll walk through the diagnosis, the treatment options, and we'll wrap it all up with some can't-miss clinical pearls.
All right, first up, the balance of continence. You can't really figure out what's gone wrong until you have a crystal clear picture of how the system is supposed to operate in the first place.
So what is urinary continence? Well, it's pretty simple, really. It's the ability to control your bladder. But the magic is in the details. It all comes down to this super delicate, coordinated dance between 2 key players, the bladder muscle, which we call the detrusor, and the urethral sphincter.
This slide right here is absolutely high yield. It breaks down bladder function into 2 basic states. I want you to think of the bladder as a balloon, that's the detrusor muscle, and its opening as a valve, that's the sphincter. So when your bladder is filling and storing urine, the balloon is relaxed and stretchy, and the valve is clamped shut. When it's time to urinate, the complete opposite happens. The balloon contracts and squeezes, and the valve relaxes and opens up.
And that's the whole game. Incontinence, in all its different flavors, is basically just a breakdown in that perfect coordination. Either the valve is too weak to stay shut against pressure, or the balloon squeezes down at the wrong time.
Okay, moving on. Now that we've got the normal physiology down, we can talk about what happens when things go wrong. Let's break down the major ways this control can be lost.
This table, this is your cheat sheet for diagnosis. Definitely an exam point. First, we have stress incontinence. That's leakage with a cough or a sneeze. The problem here is the sphincter. It's too weak. Next is urge incontinence. That's the sudden, gotta go right now feeling, followed by a leak. The issue here is the detrusor muscle being overactive. Then there's overflow incontinence, the constant dribbling. This happens because the bladder is just too full and can't empty, usually because something's blocking the exit, like an enlarged prostate. And finally, functional incontinence. Here, the urinary system itself is working fine, but a physical or cognitive problem prevents the person from actually getting to the toilet.
Now, it's really important to know that in the real world, patients don't always fit into one neat little box. Actually, the most common thing you're going to see is mixed incontinence, which is a combination of both stress and urge symptoms.
So, we know the types, but how do we figure out which one our patient actually has? That brings us to our clinical investigation. And I'm telling you, your most powerful tool isn't some fancy, expensive test. It's simply asking the right questions.
You want to approach this like a detective. Your first question should be about physical triggers. Does leakage happen when you cough, sneeze, or laugh? A yes there points you straight towards stress incontinence. Next, you ask about the sensation. Do you get a sudden, overwhelming urge right before the leak? That is the classic story for urge incontinence. And finally, you ask about the pattern. Is it more of a constant, slow dribble all day? That should make you immediately think of overflow incontinence. Once you've got a good idea from their story, you need to do a couple of basic tests. A simple urinalysis is a must because a UTI can mimic any of these symptoms. You have to rule it out. And you'll also want to measure the post-void residual, or PVR. It just tells you how much urine is left in the bladder after they go. A high PVR is a big red flag for an overflow problem.
What about the more advanced stuff, like urodynamic studies that measure bladder pressures? Well, you usually don't need those right off the bat. They're really reserved for the more complicated cases, like when your first-line treatments haven't worked or the diagnosis just isn't clear.
All right, let's get to the part that matters most to our patients. What can we do about it? This section is all about the pathways to treatment. And remember our guiding principle. You match the treatment directly to the type you diagnosed.
Now, before we get super specific, there are some foundational treatments that are good for almost everyone. This is a big clinical tip. We're talking about things like bladder training and time voiding to regain a schedule, pelvic floor muscle exercises, you know them as Kegels, and some lifestyle changes like managing weight and fluid intake.
Okay, let's get specific. For stress incontinence, what's the core issue? A weak support system, right? So the treatment is all about strengthening that system. That means intensive pelvic floor physical therapy. And if that's still not enough, surgical options like a mid-urethral sling can be incredibly effective.
For urge incontinence, the problem is that overactive bladder muscle. So the goal is to just calm it down. This is where medications are a huge help. The main options are antimuscarinics and beta-3 agonists, and they both work by helping the bladder muscle relax, which allows it to hold more urine.
And finally, for overflow incontinence, it's a two-step approach. First, you have to relieve the pressure and drain the bladder, which might mean using a catheter. Second, and this is the crucial part, you have to treat whatever is causing the blockage. For many men, that means treating an enlarged prostate or BPH.
We have covered a ton of ground. So let's lock it all in with a final, rapid-fire review of the most high-yield pearls to make sure these key concepts really stick. Ready? Let's do it. Stress equals leakage on a cough. Urge equals that sudden, intense need to go. Overflow equals constant dribbling. Kegel exercises are first line for most types. And always think of BPH as a common cause of overflow in men.
And if you remember absolutely nothing else from this, please remember this. The patient story is your most powerful diagnostic tool. A careful, thoughtful history can get you to the right diagnosis in the vast majority of cases.
So, the next time a patient comes to you with urinary incontinence, you've got this. You have a clear framework to identify the type, and that's what illuminates the path to effective treatment. So I'll leave you with a final question to think about. Now that you can tell the difference, which one of these types do you think you'll be seeing most often in your clinical practice?